Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today on the show, we have Taylor Gurley. She's a professor of occupational therapy. Her Kevin MD article is titled, U.S. Adults Should Get Routine Anxiety Screening, but Then What? Taylor, welcome to the show.
Thank you for having me.
So we'll get into your article in a little bit, but first off, briefly share your story and journey to where you are today.
Absolutely. So, yes, currently I'm a professor of occupational therapy at the University of Indianapolis. Prior to transitioning full-time into academia, I was a full-time practitioner working primarily in outpatient pediatrics, serving families who have children with disabilities from birth to about 18 years.
All right. So what's something about occupational therapy that's not immediately obvious to my clinician audience?
Yeah. So I feel that occupational therapy is generally assumed by everyone as working on your job or helping kids with handwriting. I feel like those are the two pigeonholes we get stuck into. And it's really a diverse field. We graduate entry-level practitioners to work across the lifespan. So we really just help increase the use of everyday occupations and making sure people can be successful and independent completing those. So that could be anything from being able to shower independently to commuting to work. So all of the different cognitive and physical skills that are involved in a wide array of activities.
So I'm a primary care physician. In a primary care setting, what are some pictures of patients or tip-offs that would make me think in the back of my mind, hey, maybe occupational therapy would be right for this patient in this setting?
Absolutely. So in primary care, occupational therapy can work with people in pretty much three different areas. So someone who is on the cusp of maybe meeting a diagnostic criteria, let's say of type 2 diabetes, we could work with that individual to create new, healthier habits and routines to decrease the likelihood that they may meet that diagnostic classification. We could also work with someone who's newly diagnosed with maybe multiple sclerosis or any sort of cognitive decline, any mental health diagnoses, anything that would really impact their ability to complete those daily activities to their highest level. And then the last category of patient would be anyone living with a condition that has some irreversible components. So we would then look at how can we adapt the environment to better serve them? How can we modify how they're currently completing tasks, again, to promote the highest level of independence? So that's where in primary care, again, it could be across the lifespan, but those are the three main areas.
All right. Let's talk about your Kevin MD article. It's titled, U.S. Adults Should Get Routine Anxiety Screening, but Then What? Now, in your world of occupational therapy, how did you get interested in anxiety?
Yes. So when I was a pediatric outpatient therapist, my employer was gracious enough to let me work with a lot of families whose children were having high rates of anxiety. And these kiddos, they could not complete their homework assignments. They were having disruptions in school. And then what we really saw was this untreated anxiety was affecting the entire family unit. So I spent a lot of my clinical career addressing anxiety and depression within family systems. And then when I moved into academia, I started studying it, researching it, and receiving more training on how to address these two conditions from the occupational therapy lens, regardless of age or diagnosis. So that's really what led me to write this article. And I was thrilled to see that our United States Task Preventative Service created this guideline. But then I felt it really left a gap in what do primary care physicians do next. We're screening for all of these things. And I thought this is a really great entry for how to advocate for my profession to be integrated a little bit better into that setting.
And you talk about the U.S. Preventative Services Task Force. You're right, they did now recommend all primary care physicians screen for anxiety as standard practice. So tell us about what options are available typically once a primary care clinician screens for anxiety and comes up with signs and symptoms that may be suggestive of that.
Sure. It would very depending on each patient. If a patient came to their primary care physician and said, I'm experiencing all these negative things and I need a little bit more direction, that could be the first indicator that the screening is going to take place. And a patient like that might be open to being a little bit more high level in their treatment in terms of following whatever recommendation is given by the physician. So they may take physician recommendations for increasing quantity and quality of sleep, maybe changing their exercise routine, some of their eating habits to have like a natural reduction of anxiety symptoms, or they might be willing to follow a recommendation for the use of a pharmaceutical. The group of people I would want to be targeting as the OT are the ones that the physician is noticing. There's something going on here. I'm seeing some red flags for anxiety, for depression, and then asking the patient, would it be okay if we went ahead and screened you for this? I think we might have something going on.
What would some of those red flags be?
Some of those red flags would be perseverating on any physical ailment that they may be experiencing, not having any success following through on prior recommendations given by the physician, worrying. Physically, this can show up with some hair pulling, skin picking, any negative sort of behavioral tendencies can develop from untreated anxiety, and that those have their own diagnostic classifications. So we would want to catch that up front if that was happening.
And these are the cases that you think would be best suited, or an occupational therapy approach would be an option for these type of patients.
Absolutely. So the patients who maybe they are just overwhelmed with life, they don't have a whole lot of time, they feel, to make these changes, we're the ones that can come alongside them and show them how that is done. And the reason OT is so successful in this is because we do directly embed it into their daily routine. So we're not necessarily asking, do this whole new thing that you have never done. We're going to take what you're currently doing, we're going to modify and adapt it to fit right in with your routines. We're just hopefully going to make those healthier for you.
So tell us a story or a case study. Let's say I recognize these symptoms in one of my patients and I decided to send this patient to occupational therapy for anxiety. Tell us a story about what you would do and how that would move the needle.
Sure. So if we had a patient who was experiencing restlessness, they can't, steady their thoughts, they're increasing their worries, we might use some cognitive behavioral techniques with them to help them move towards a more mindful state. So coming into their body, out of their mind, doing breath work, doing a little meditation, something that they are interested in. And that's the key. That's the professional norm. We're not going to recommend or have them do things that they don't value. So once we identify what's valuable and what that motivator could be, we're going to use that and we're going to say, all right before bed, you turn your lights out. We're going to have you do this routine as you're laying in bed preparing for sleep. And then we're going to track that and we're going to collect data to see, was that successful in calming your thoughts, in organizing yourself, in slowing your heart rate down so that you could be more relaxed, in the example of, increasing sleep quality.
Now, how often would that patient have to come see you?
That would just be determined. Each clinician would have to make that clinical judgment based on spending evaluation time and treatment time. But really in primary care, the great thing is that we can bill occupational therapy services on our own as our own service provider. So we would work with the patient as well as their insurance to see how much occupational therapy can be approved per year. And then we would work with that person on determining, do we need to see you once a week, bi-weekly, and just come up with a treatment plan for them that would be the most beneficial. We can also work from a telehealth platform. So we might be able to see them in office for an evaluation and then touch base and do our treatment sessions on a virtual platform if that's more feasible.
Now, in general, within the spectrum of what you offer as occupational therapists, what proportion does anxiety play a role in terms of what you guys do in the spectrum of what you do?
Sure. So there's only about 3% of occupational therapists that work only in a mental health setting. However, regardless of what setting you are practicing in, if your patient has unmanaged anxiety or any other mental health condition, that's going to become a barrier and a roadblock. So, one thing I always teach my students is you might say you're not going to be a mental health occupational therapist, but you will always be addressing mental health in a hand clinic, in a rehabilitation facility, in a skilled nursing home. Those are barriers that we have to actively work to overcome in order for our patients to reach their goals.
Now, is treating anxiety, is that within the scope of training of all occupational therapists? Do you have to look for someone who has a special interest or specializes in behavioral health?
Sure, that's a great question. So it is within the scope of all occupational therapists who are credentialed, licensed, board certified in our specialty. Now, it is the ethical responsibility of each entry level practitioner to receive continuing education within those more specialized areas that they want to practice in. However, it could be anxiety, it could be any label you want to give it. If it's interfering with an individual's ability to complete their daily routines, that's in the scope of OT. So we're not treating a diagnosis, we're treating a person and the deficits that are coming because of a diagnosis.
Now, we focus specifically on anxiety, but as you can imagine, there are a variety of other behavioral health issues that can affect with occupational therapy issues. Now, would you address some of those other behavioral health issues outside of anxiety?
Absolutely. And it's honestly pretty uncommon for any of us to just have a patient with only anxiety. That might be what is the most obvious on the surface, but then when we start really working with them, we're able to see some of the deeper issues that are there. Is it decreased self-esteem, self-worth? How does that change the way that they show up in the world and in their workplace or in their school?
We're talking to Taylor Gurley. She's a professor of occupational therapy, and her Kevin MD article is titled U.S. Adults Should Get Routine Anxiety Screening, but Then What? Taylor, what are some of your take home messages that you want to leave with the Kevin MD audience?
I would love to leave the audience with just an increased understanding that occupational therapy can be a wonderful support service in the primary care setting. So we would be there to help your patients do the things that you are asking them to do. So if you're a physician and you're finding yourself a little bit frustrated that things are not happening each time you see your patient, we could be a support in order to help increase the infrastructure that surrounds you.
Taylor, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you so much for having me.